Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about rheumatoid arthritis. When I left up last week, I was in the middle of talking about the different treatments that are available for rheumatoid arthritis. Namely, I went through the medical treatments with all the medications. I mentioned the rheumatological treatment, and I talked about the orthopedic treatment. That's when I left off. Now, I was talking about the fact that it is very frequent that orthopedists will give people with severe rheumatoid arthritis of different joint. The joint is so painful, so swollen, whatever. There's no fluid on it. It's just the inflammation, and they would then inject a steroid into the joint together with some anesthetic to try to relieve the pain, because the steroid would locally decrease the inflammation. Problem is, as I mentioned last week, I started to talk about the fact that this is a very good treatment, and I'm not an orthopedic doctor, but I can tell you too many steroid injection is not a very good idea, because inevitably, if one continues to get the steroid injection, there's a syndrome called avascular necrosis might happen. What is avascular necrosis? Well, it's a situation whereby the steroid itself destroy the blood vessels that are carrying blood and oxygen to that particular joint, to the point where the only option left is to remove that joint, whatever the joint happens to be. It's a very sad situation, but it can happen. So that's one of the complications that I wanted to clarify. Also, I said last week, you cannot have rheumatoid arthritis don't become anemic. It's impossible, because rheumatoid arthritis is an inflammatory / autoimmune disease. And whenever you have a chronic inflammatory disease, it is inevitable that you won't be able to carry iron from the circulation into the bone marrow very easily, because there's a block. The infection and the inflammation in this case blocks the ability of the iron particle to cross over into the circulation, to be grabbed by the transferrin receptors, to be carried into the bone marrow, to be incorporated in early baby red blood cell to produce mature red blood cell to avoid the anemia. There's a block there, so the iron backs up. The iron sits there and it keeps backing up. The more the inflammation persists, the more the iron is going to back up. And the iron is, we test that as ferritin. The ferritin is going to be very high. And then you have a form of anemia, which is basically anemia of a chronic inflammatory disease. Now, here's the problem. You already have one problem with the joints, with an S, with the inflammation that's taking place inside them, causing destruction. Now you have a second problem, which is secondary hemochromatosis, namely secondary iron piling up. That's called iron overload. The secondary, there's primary, there's secondary. There's many, many, many forms, reason for secondary hemochromatosis. This book that I just wrote, The Best of Medical Oncology and Clinical Hematology, that just came out a few months ago at the beginning of the year, there's two big chapters there. There's a chapter on primary hemochromatosis, which is iron overload. There's a big chapter on secondary hemochromatosis. And of course, what secondary is, the fact it is the inflammation that's causing the iron to pile up. Now, there are situations where it could be hemolysis, that one hemolyzes and then you dump iron into the circulation. Everybody will have chronic inflammatory disease of one type or another, chronic hemolytic disease of one type or another, subsequently wind up with too much iron in the circulation because it piled up. Now the problem is, you already have a primary inflammatory process. Now imagine wherever the iron is piling up, it could be in the joint as well. You're also going to get inflammation because of it. You say, well, how so? Well, the iron does just not sit there. It sits there by necessity. It must degrade. And as the iron that sits there is degrading, wherever it's located, it could be in the heart, the lungs, wherever, you're going to wind up with free radical being released. Once you release free radical, that's the beginning of an inflammatory process. So that's a double whammy. So that is why it's very important to monitor what is going on. Well, how do you monitor what is going on? Well, you monitor what is going on by checking the sediment, by checking the rheumatoid factor, by checking the ferritin level. Those are the three things that's going to tell you how inflamed the stuff is without you being able to touch it, how intense the inflammatory process. See, well, this is rheumatologists and, for that matter, orthopedic doctors and general internists, for that matter, cannot do their work properly in certain form without having the help from the test called sediment. And the sediment is very simple, very cheap. All you have to do is draw some blood in a lavender tube, shake it up, and you're going to put it in a very long tube. The tube is marked from 0 to 100, and you're going to sun it up at room temperature. And there's a little rubber thing we put so that the tube stands straight. And you just time it for 1 hour. And you're timing it for 1 hour, and from the top all the way down. When the 1 hour is up, where the plasma meets the red blood cell, that's the number of the sediment. That's the sediment number. And the normal sediment is from 1 through about 20 in some laboratories, 25, 30 in some laboratories. And that's very crucial, because the more intense the inflammatory process, no matter where it is in the body, the higher the sediment is going to be. The more intense the infection is wherever it is in the body, the higher the sediment is going to be. That's a very cheap, simple, but it is crucial. And of course, you talking about rheumatoid arthritis, you would have done a rheumatoid factor to help you diagnose this process. Well, then you check the rheumatoid factor. The same time you're checking the sediment. And the better the response, the lower the sediment, the lower the rheumatoid factor. Now, that's just the way we manage it. You say, well, for academic reasons, because as I said, many students and physicians, etc., watch this show across the world, you want to know what causes the sediment to work. What is this all about? Something so simple, yet it is crucial, because there's a substance all of us have in our body called fibrinogen. The fibrinogen is a phase 2 reactant protein. It is the fibrinogen, let me repeat that, it is the fibrinogen in our bloodstream that allows the sediment to work. Without fibrinogen, the sediment will not respond, period. Okay? And you got to be super careful, super careful, so you understand what this is all about. If you do the sediment, I'm a teacher, so, and I'm not going to make an excuse for teaching. I'm going to try to help you to understand, while you're taking care of one disease, how easy it is to have a red flag for a possible other diseases, because if the sediment does not respond, and you're doing it the right way, you put it at room temperature, it didn't respond. So you could take it and put it at a temperature that is higher than that of the room temperature. And if it responds at that time, you just diagnose. If you understand clinical medicine, especially the academic type properly, you've just landed your hand on a possible series of diseases that are extremely important. All of them are lymphocyte malignancy type diseases. They call them cold agglutinin. Okay? If you put your sediment at a room temperature, it's a cold situation, normal temperature, it didn't respond. You take that same tube and you put it at a higher temperature and it responds. You just diagnose cold agglutinin disease, which is a long list of several lymphocyte associated problem. You just hit it right there, the red flag right there. Wow, something is going on. Okay, I'm not going to bore you with a whole lot of other tricky little questions that can cause the sediment not to respond, etc. I'm not going to bore you with that, but the big picture, I just gave you what the big picture is. Okay, so, and of course, the sediment does not respond at all. The patient hematocrit is okay, then you say something is wrong here. The steroid should respond, it doesn't respond. Well, you go and check the patient fibrinogen, because there is a condition where people have no fibrinogen. That's a major medical problem. So this is what I'm saying to you. If you know what these things are, look at, you don't need $1 million machine. Yes, your brain over your shoulder that can help you to save patients' lives by simple things like that. And they're not complicated. They don't have $1 million price attached to them, but you understand them, and that can help you not only to practice better medicine, most important of all, to help the patients, which is basically the main reason why you are in this business, to help people, human beings, your fellow human beings. Okay, now, if, of course, the patient is very anemic, patient is having symptoms because of the anemia, and or the patient is getting ready to go to the OR for a procedure or whatever, and the red blood cell is too low for anesthesia to be administered, and you don't want to transfuse the patient if you don't have to, because you have time to plan this, it was not an emergency situation, then there are things you could do. I'll give you a classic, easy example. It is very frequent that orthopedic surgeons are planning to do surgery to, let's say, to the knee joint. Give that as an example. You could coordinate that with the internist and or the rheumatologist to plan that the surgery is going to be done 6 weeks, 2 months from now. All you have to do is to take that same patient with a very low hematocrit, with a very high serum ferritin. You're going to treat that patient with Epogen / Procrit. That's right, Epogen, which is really man-made erythropoietin, which is the hormone that the kidney produces that allows us to produce red blood cells. Well, it's not going to work. The natural one is not working. Okay, so what can you do? You inject the patient with Epogen on a scheduled basis, and you're going to mobilize. The Epogen is going to mobilize, overcome the block, bypass the block. It's going to bypasses the block, jump over the block, allowing the transferrin receptors to grab onto the iron particle and take it into the bone marrow. Let me repeat that. The Epogen is going to overcome the block. All that pile of iron that's sitting here, doing nothing but causing you harm. As soon as you begin to give the patient the Epogen, that iron, the block is going to be brought down, and the Epogen is going to pushes the iron over. That's right, pushes it over. Once it's sitting over here, you got plenty transferrin receptors sitting here doing nothing, because there's nothing for them to do. In fact, you could measure them clinically like now. They're going to be very happy to grab onto that iron and rush it into the bone marrow. So you could we could prepare the patient weeks before by doing just what I just told you. And that is being done for many, many, many other conditions across the world and in this country for the people who really understand. You have got to understand this stuff. If you do not understand it, my God, there are so many people in this country and elsewhere that understand this stuff. Bring them into the picture so they can help you, because you can't go start transfusing the patient, because the patient already have too much iron, and each unit of blood you give that patient has 250 milligrams of iron in it. Not only all the possible contaminating stuff that can happen with the blood transfusion being given, even though now blood is reasonably better safe now than it used to be years ago, much better safe. The point is that it's not necessary unless it's in an acute emergency situation where somebody get into an accident, or somebody's bleeding from the GI tract or the GYN tract or the urological tract for some other reason. Then you have time to plan this by doing something, okay, what I just explained to you. And that is being done for a whole host of other conditions, okay? Because there's a lot of reason why you don't want sometimes to overload people with more iron. They already have too much iron. As a matter of fact, Even people who have hemolytic diseases, we are using, for such the thalassemias, we are using, there are a lot of chelating agent that can be used, but you could quickly also mobilize iron by giving them procreate and epogen and so on and so forth. Okay, so this is one way to help the situation. But if you don't know this stuff, please, there are plenty of other people out there that know this stuff. I'm not unique. I'm not the only one. I don't have a monopoly to this knowledge. It's all over the place. Just I've got to find the right person to help you. So for the benefit of the patient. Now, again, you have to understand something. Rheumatoid arthritis may not be just rheumatoid arthritis. There's a condition called mixed connective tissue diseases, which is when the other conditions of a rheumatological nature or of inflammatory nature or autoimmune nature that may be associated with the rheumatoid arthritis that causing things not to work out the way you want to work out the way you want to, but you have to know how to discover these other things. Simple stuff, not $1 million machine, because you already know if you have one rheumatological condition, and I'm telling you, you live long enough, you're going to have one or two more. The same thing if you have one autoimmune disease, it is just about guaranteed. You live long enough, you're going to have one or two more. You have got to prepare the situation for that. From the minute you're involved, you got to do the baseline to make sure that you're dealing only with rheumatoid arthritis and nothing else, because that then can complicate the situation. Let me give you an example of the complications that can be associated with rheumatoid arthritis. The list is quite long. I won't read all of it to you, but I'll give you an idea. Vasculitis, involving medium-sized vessels, which is an inflammation inside this vessel that can be very painful and very dangerous, can be associated with rheumatoid arthritis. The lungs can cause, there could be fluid effusion, resulting in shortness of breath. Diffuse interstitial fibrosis may develop, resulting in chronic lung disease and death. Recently, within the last couple of years, there have been many articles in the literature that shows that people who are being treated for rheumatoid arthritis may in fact wind up dying from chronic fibrosis of the lung. And they cannot breathe, and no matter what you do, and these people wind up losing their life because their lungs, if their lung is not functioning, you cannot perfuse the brain properly, you cannot perfuse the heart properly, you cannot perfuse the kidneys properly because the lungs cannot pump the blood to deliver the oxygen, and all these organs wind up failing. And it has been known before, but for a reason that's not clear, more recently there's basically been really a series of articles describing how bad a disease, rheumatoid arthritis, really is as it relates to all the other complications. Okay, let's talk about the eyes. The eyes may be involved. Conjunctivitis, okay, Zika, also known as Sjogren's syndrome, can cause dry eye. So somebody may have rheumatoid arthritis, and all of a sudden they're having this dry eye problem, or they may develop Sjogren's syndrome, which is another one of those associated disease that may be persisting, maybe even more annoying, more disturbing to the patient than the rheumatoid arthritis itself. Now, why would you be paying so much attention to somebody's white blood cell who has rheumatoid arthritis? Well, there's a condition called Felty syndrome, where 10% of people with rheumatoid arthritis develop severe leukopenia, low white blood cell, which exposes them to infection of different type because they have low white. In particular, there's certain subgroup of people, such as Negroes like myself, who were born with with lower white blood cell count than Caucasian folks. In fact, I've had patients in my practice, no matter what I do, they have white blood cell 1,500, and I had to keep them going. The median white blood cell for Caribbean folks is 2,600, and the subgroup of folks with the lowest white blood cell count are people who come from certain part of Africa. Okay, you have got to understand these things. This is because you cannot. This is why it is now recognized clearly. You cannot practice medicine in a high quality form to anyone whose culture that you're not familiar with and you're not sensitive to it. Now this is a fact. I've been talking about it, get myself into a lot of trouble. People coming after me because I think I'm saying things negative. I'm not. It turns out now that the AMA and the other powers to be, the American College of Physicians, etc., now have recognized that fact to the point right now. In addition to the M.C.A.P that you have to take to get into medical school, now there's another exam I just found out recently that you also have to take that deals specifically with ethnic associated issues. And for that matter, when you do, the time does come for you to take your board, hallelujah, I wish you luck, because there's going to be tons packed with ethnic associated questions that you have to be familiar with, and you must answer them correctly, otherwise you're not going to pass that exam. Because now the powers to be realize now in order to practice quality medicine, you got to be evidence-based and patient-oriented. So now all the new folks that are getting into medical school right now, this is the new ball game. You may not like it, that's your problem. But the people who are teaching you, even in the residency, in medical school, they're now getting grants. The AMA itself has given grant to many medical schools in this country that have taken the grant because they agree to teach medicine in a evidence-based, patient-oriented. They're taking the grant. That's the new thing. If you don't like it, that's your problem, because you have to deal with it. Because you cannot, and I repeat it, and I'm a teacher, and I teach all different ethnic groups. There's not a country in this world, without bragging, where the sun rises in the east and set in the west, that we don't have people that I taught medicine the Valiere Alcena way. Yes, there is quality medicine. There's also the Valiere Alcena way of practicing medicine. And I'm being truthful, not arrogant, factual. So you have got to understand these things, and you can't just stumble on it. If you think you're going to stumble on this thing by luck, I wish you luck. It doesn't happen. You have got to know these things. Okay, again, people with rheumatoid arthritis, childhood rheumatoid arthritis can develop still disease, fever spike, polyarthralgia, myalgia, a whole host of pericarditis, pneumonitis, sore throat, large spleen, as I mentioned, lymphadenopathy, pain in the abdomen. All these things, because rheumatoid arthritis is a systemic disease, okay? And the heart can be involved very significantly with pericarditis. You may have aortic regurgitation. All these things can be associated. There is no organ in the human body that is not affected by rheumatoid arthritis to one degree or another. You have to know it, or then you shouldn't be taking care of patients. Then you have no business taking care of patients if you don't make it taking up with yourself to learn this stuff. Because there are people out there that, as a teacher, let me tell you, nothing that people teach like more than teaching folks who wants to learn. I know once somebody wants to learn, oh, Mike, you have no idea. I had a case at Montefiore in the Bronx several years ago. A young man from one of the Latin countries was a resident, an intern, and I was his attending. This guy, he couldn't get it together. A very smart man, but could not get it together. They were about to discharge him from the situation. I said, no, do not discharge this guy. This is a young man. He's very Give him to me. I said, give him to me. They agreed to give him to me, and for 3 years in the internal medicine program at Montefiore, I taught this guy. I teach him how to think properly, how to logically do things. And one day, I'm sitting in my office. I got a phone call. Dr. Alcena, I'm also, I said, what are you so excited? I just passed my internal medicine board. I said, I taught this guy. He passed his board. Yes. This is the same guy they were about to, there was nothing they could do. He just could not put two and two together. I, I said, do not do that to him. Just give him to me. Just give him to me. I'll take care of him. I said, okay, Val, you say you want, take him. Okay, and for 3 years, his internship, first year residency, second, this is how you do this. This is what this and that. This is that. Okay, and for years, in case you did not know, I was also someone who sort of, well, I shouldn't be telling you these things. Anyway, I just want to tell you that for years I was involved with I don't want to go there because I don't want to say things that are confidential. Suffice it to say, I prepped this guy, and he finished his training. He's doing great. He passed his board, etc. Okay, so you have got to know how to think. You have to think logically. So nowadays, as I said, it is not me. Yes, I've been beaten up all over the place because I've been pushing that notion for people to provide quality care for everybody. You must be sensitive to the ethnicity, and you must understand the ethnicity. Otherwise, you cannot provide, because different ethnic groups have different diseases that are more prevalent in them, and different individuals present with symptoms differently when they have certain disease, and you have got to understand that. You have to understand that when you're dealing with different ethnic groups, don't expect everybody to behave the same way, to present, to explain things to you the same way. And what you're going to do is your job as a doctor to very calmly learn how to take a history from different patients. Period. If you can't do it, then you have no right being in this business. Find something else to do. So rheumatoid arthritis, as I stated, is a very serious problem. Very serious problem. And then when I get back to talking about it again, arthritis next week, I'll begin to talk a little bit more about this combination at different diseases that cause different problems as it's related to arthritis. Again, I want to take a moment to tell you, pay attention, wear your mask, keep your distance, wash your hand with soap and sanitizer, and stay away from crowd and listen to what the authorities are telling you, because this disease, COVID-19, is real. Take care until I see you again. This is Dr. Alcena saying so long and bye-bye.